Assalamualaikum warahmatullahi wabarakatuh. Hello, ladies and gentlemen. Thank you for having me as one of the speakers for this seminar. My name is Sheilla Restiani Putri with NPM H1A021013. I'm a medical student at Faculty of Medicine and Health Science of Bengkulu University. I will present an article about contact allergen sensitivity in children with contact dermatitis. This article is written by Esra Yücel and Deniz Özçeker. Published by U.S. National Library of Medicine, National Institutes of Health at 1 January of 2021. There are 6 parts of this article that I will present: introduction, aims, material and methods, result, discussion, and conclusion. First of all, do you know contact dermatitis? Inflammatory dermatosis caused by substances in contact with the skin are called contact dermatitis. And if we evaluate it etiologically, it is classified as allergic contact dermatitis or ACD and irritant contact dermatitis or ICD. Allergic contact dermatitis is defined as an allergic or inflammatory skin reaction due to a late type of hypersensitivity reaction that occurs in subsequent contact of the previously sanitized person with a chemical, physical, or biological allergen substance. Although it is less common than adults, it is increasingly common in childhood as a result of ear piercing, temporary and permanent tattoo at an early age, and increased use of cosmetic products, and even in adolescents, it is almost as common as adults. Evaluating a large case series, the rate of sensitization in childhood and adolescence was found to be similar to adults. A significant increase in the rate of patch test positivity is noticed in children, and it is thought that this may be related to both increased allergen sensitivity and more widespread use of patch testing. In patients with allergic contact dermatitis, early detection of the sensitive allergen helps to reduce the long-term use of topical steroids by preventing exposure, because allergen avoidance results is an improvement in clinical findings. Okay, move on to the next part is aim. In our study, we aim to determine the frequency of contact allergen sensitivity and the allergens most frequently detected in our patient. Next, materials and methods. We can divide it into 5 parts. The first part is patient selection. We evaluated file data of all patients between the ages of 1 to 17 years old who were diagnosed with contact dermatitis and admitted to pediatric allergy and immunology outpatient clinics between March 2017 and February 2018. Patients with concomitant atopic dermatitis, contact urticaria, and other chronic dermatosis were excluded from this study. The diagnosis was made based on the location of the lesions, clinical features, and clinical improvement by avoiding the allergen if detected. The second one is laboratory test. We recorded demographic characteristic, presence of atopy in the family, locations of the lesions, itching score according to visual analog scale, skin patch test results, serum total of IgE, blood eosinophilia percentage, skin prick test results for respiratory and food allergens. Patients with serum-specific IgE antibodies or positivity to at least one allergen in the skin prick test were evaluated as atopic. A blood eosinophil percentage higher than 4% or 450 millimeter was considered as eosinophilia. The third one is skin prick test. We perform the skin prick test or SPT using standard methods as allergen extracts, Stollergen's friends, Dermatophagoides terracinus, Dermatophagoides farinae, Blatella germanica, Felis dermaticus, Canesis, Aspergillus fumigatus, familiar Penicillium mixture mix, Clasodium rumex acetosa, Urtica dioica, and etc. So a total of 34 allergen extracts were used, and histamine of 10 milligrams was used as a positive control, and saline solutions were used as negative control. 1 drop of allergens, positive and negative control extracts were dropped to the inner surface of the forearm at 2 centimeters intervals. The skin was pierced into with a lancet of 90-degree angle over each drop. Evaluations were made 20 minutes after the test was administered. Detection of higher than 3 millimeter wheel diameter compared to negative control was considered as positive. Skin patch test. Skin patch test consisting of 36 allergens, nickel sulfate, wool alcohols, neomycin sulfate, potassium dichloramate, cane mix, fragrance mix, colophony, paraben mix, blank patch, and etc. Before the patch test, patients were warned not to use systemic steroids and antihistamines, and not to use topical steroids, creams, and ointments in the test area. The standard envelope was opened and the ready-made test material inside was attached directly to the back of the skin. The patients were warned that the test area should not get wet and that activities that could cause the tapes to come off their places should not be performed. The patch test was removed after 48 hours by 2 allergists, and the test area was evaluated after 30 minutes. The test site was re-evaluated at 72 or 96 hours to detect late reactions. The results were interpreted as negative if there was no reaction, erythema, and infiltration, papule, vesicle, bulla, as recommended by the American Academy of Dermatology. Written consent was obtained from the patient and their parents before the patch test. The last one is statistical analysis. When evaluating the findings obtained in the study, IBM SPSS statistics for statistical analysis program was used. The suitability of parameters to normal distribution was evaluated with the Shapiro-Wilks test while evaluating the study data. Besides descriptive statistical methods, the student t-test was used for comparing normally distributed parameters between 2 groups, and Mann-Whitney-U test was used for comparisons of parameters that didn't show normal distribution between 2 groups while evaluating the study data. Next, here we can see the results presented in table. From the first table, we can conclude that a total of 80 children, 45 or 56.3% of girls, and 35 or 43.7% boys, aged between 1 and 17 were included in the study. The mean age of the children was 7.37, and the longest duration of complaints was 15 years. We can see the clinical and demographic characteristic of the patients in Table 1. Next, the second table. The median serum total IgE value of the patients was 125, and the mean percentage of eosinophils was 4.06. Positive response to at least one or more allergens was detected in 57.5% of the patients who underwent of skin patch test. Among the patients who were found to be positive, the location of the allergen and the lesion was compatible with 76%. The most common allergen is nickel sulfate by 14.8%, as the result of the allergens detected in the skin patch test are given in Table 2. In the third table, we could see that when the patch test positive patients were compared with the negative ones, the H values of those with positive patch test results were found to be significantly lower than those with negative patch test result. In the fourth table, we could see that no statistically significant difference was found when the age, gender, duration of complaints, purity score, IgE, and eosinophil parameters of patients with negative and positive nickel results were compared. Okay, move on to the next part is discussion. A positive response to one or more allergens was detected in 57.5% of the skin patch tests in our study. This rate was reported as 4.5% in other studies conducted with children. In our study, the mean age of patients with positive patch tests was found to be lower than those with negative. Although contact allergen sensitivity is expected to increase with age, this finding may be an indication that contact allergen sensitivity can start at an early age and can be detected at a young age. The most common allergen was nickel sulfate with 14.8% in our study, and nickel sulfate is reported to be the most common contact allergen in adults and children worldwide. According to European Union regulation, it is recommended that the nickel release rate in products should not exceed 0.5 microgram per centimeter per week. Although nickel sensitivity is expected to decrease with this regulation, the presence of the tradition of ear piercing at an early age in our country, the widespread use of metal accessories and piercings, as well hairpins, metallic fabric prints, coins, lip paint, watches, zippers, rings, earrings, studs, metal buttons, belt buckles, nickel-containing batteries, metal toys, kitchen and bedroom items still cause nickel sensitivity to be detected most frequently with the increasing contact in daily life. Ci plus isothiazolion, or MCI, is the second most common contact allergen detected in our study with a rate of 10%. MCI is a presentative as a mixture of 3:1 ratio in moisturizer, powders, sunscreen, shampoos, liquid soaps, toilet paper, wet wipes, non-rinsing cleaning materials, and it is considered as a weak contact allergen. But a lot of cases of ACD localized in the face and perineal region have been reported in children due to MCI. Tire mix is the substance used in the production of rubber. It is associated with occupational ACD in adults working in the food, health, sanitation sector. It causes face and hand dermatitis. Personal products such as raincoats, boots, shoes, gloves, balloons, pacifiers and baby bottles, rubber hands, erasers, socks, and elastic bands on underwear, which children frequently use in their daily lives, include Tyra mix. We think that the widespread use of these products among children may increase this sensitivity. Allergic contact dermatitis localization was most frequently detected in the hand and the face. 41.3% and 22.5% in our study. Allergic contact dermatitis causes serious deterioration in the quality of life of the person, especially when it is localized on the hand and the face. Since the distribution of positive allergens in our study was wide, stratification could not be performed, so the frequency of allergens could not be evaluated according to lesion's localization. Next, the conclusion of the study. Allergic contact dermatitis and allergens that cause sensitizations are found with increasing frequency in children and the younger age group. The awareness of physicians on this issue should increase, and to determine the responsible allergen with the skin patch test should be tried. Avoiding the responsible allergen will ensure the control of the lesions and prevent their recurrence. Avoiding long-term use of topical steroids and thus increasing the quality of life of patients. Maybe that's all I can say. Thank you for your attention and see you on the next seminar. Wassalamualaikum warahmatullahi wabarakatuh.